As Sarah said, it was a terrible pandemic. It was the worst pandemic in a century, and there's no gainsaying that. In Italy, it was terrible. In New York, it was terrible. The worst flu since the Great Flu of 1918 to 1919. But the policy response was also extraordinary. Never before in human history have we tried to suppress a virus on this scale. By early April 2020, half of the world's population was living in some form of lockdown, 3.9 billion people, an unprecedented response. And of course, mistakes were made, but we need an honest and critical reassessment. And that's what I want to just give you very briefly here in the 10 minutes that are available to me. So there were decades of pandemic planning before COVID, and it's worth paying attention to what they had to say. So in November 2019, the World Health Organization put out an update of its pandemic planning documents, and it emphasized the uncertainty and the low or very low quality of evidence for the non-pharmaceutical interventions, that is school closures, workplace closures, restrictions on gathering sizes, mask mandates, social distancing measures of all kinds, everything we did before drugs and the vaccines were available. These pre-COVID pandemic planning documents examined the evidence for the efficacy of all of these measures for 2 decades before COVID. And they the overall assessment there is that the quality of evidence for their effectiveness is very low. And as we'll see too, they are emphatic that the costs will be very high. But in any case, the measures not recommended by the World Health Organization's 2019 document include contact tracing, quarantine of exposed individuals, entry and exit screening, and border closures, because these were judged to be not sufficiently effective and extremely costly, disruptive to people's lives. School closures, this document said, could have a major impact on the safety, health, and nutrition of children in lower income families in particular, and so potentially not cost effective. And it argued that school closures raise major ethical issues, for families and communities. Johns Hopkins University, likewise, the summer of 2019, just a few months before COVID, issued the same kinds of doubtful assessments of the efficacy of these non-pharmaceutical measures, and said it's important to communicate to political leaders the absence of evidence surrounding many non-pharmaceutical interventions and the adverse consequences that may follow from them. And that Johns Hopkins document said this is especially important for scientists and public health officials to communicate this uncertainty, because public officials will have an incentive to use these measures to show that they're in charge, to show that they're taking it seriously, to show that they're taking firm action. In other words, they'll have incentives to implement these measures for political reasons rather than because they're backed by sound evidence. In the UK in 2011, another such planning document said, it almost certainly will not be possible to contain or eradicate a new virus in its country of origin or on arrival to the UK. The expectation must be that the virus will inevitably spread, and that any local measures taken to disrupt or reduce the spread are likely to have very limited or partial success at the national level and cannot be relied upon even as a way to buy time. Professor Robert Dingwall, who was on the planning group that devised these principles, said during COVID, close attention was paid to whether we might shut borders, restrict internal travel, and shut schools, but we decided these things were unworkable or at worst counterproductive. He concluded as well, we had the right pandemic plan in place, but during COVID, politicians lost their nerves and ignored it. The American Civil Liberties Union finally in 2008 said this in response to other pandemic plans that were being devised by the Bush administration at that time. American history contains vivid reminders that grafting the values of law enforcement and national security onto public health is both ineffective and dangerous. Too often, fears aroused by disease and epidemics have justified abuses of state power. Coercion and brute force gratuitously breed public distrust and encourage people most in need of care to evade public health authorities. Effective preventive strategies that rely on voluntary participation do work. As long as public health officials are working to help people rather than punish them, people are likely to engage willingly in any and all efforts to keep their families and communities healthy. And finally, minorities and other socially disadvantaged populations tend to bear the brunt of tough public health measures. The American Civil Liberties Union was entirely silent during COVID. Now, there were mathematical modelers who gained influence under the Bush administration who were more optimistic about these measures based on projections, modeled projections of how social interactions would change. And just a quote from one of these documents from 2006, the pandemic influenza plan. Modeling supports school closure as an effective means of reducing overall attack rates. The modelers saw school closures as the most important of the measures to try to reduce infection rates from a new virus. The value of this intervention is maximized if school closure occurs early in the course of a community outbreak. Just how early is early enough is not easy to say. The Institute of Medicine examined these modeled projections, assembled a team of experts led by Dr. Adel Mahmoud, who was actually visiting at Princeton at the time, and they concluded that the empirical evidence for these optimistic projections was not supported by the data. They judged, for example, that total mortality in the 1918 pandemic was only weakly associated with the interventions that some cities took and that others did not, and that the non-pharmaceutical measures implemented in 1918 do not explain much variation across cities. They did not endorse the use of NPIs for future pandemics because it's almost possible to say that the interventions either individually or in combination will be effective. And they warned as well that leaders might implement NPIs for political reasons, and the public must be informed about the costs and the weak evidence for the efficacy of these measures. And Dr. D.A. Henderson, finally, who led the effort globally to eradicate smallpox, was active at the time of these original model projections and was subsequently dean of the Johns Hopkins University School of Public Health. He joined in being skeptical about the efficacy of these kinds of measures that we implemented during COVID. He said in 2006, as experience shows, there's no basis for recommending quarantine of either groups or individuals. The problems in implementing such measures are formidable, and secondary effects such as loss of public trust in government are likely to be considerable. So that, I think, is, there were differences of opinion, but there was considerable skepticism about the evidentiary basis for these various non-pharmaceutical measures, lockdown, school closures, and so on. And there was warning that they would be extremely costly in terms of general social well-being and including measures of public health. So policy turned on a dime in March 2020. In spite of these measures, lockdown policies were adopted widely across the world. The Wuhan lockdown occurred on January 22nd, 2020, the largest quarantine in human history up to that point, 60 million people. There was a lot of skepticism that greeted the Wuhan lockdown from Dr. Anthony Fauci and many others. That's something he said, I don't think we could possibly do in the United States. I can't imagine shutting down New York or Los Angeles, but the judgment on the part of the Chinese health authorities is that this is something that, in fact, is going to help in containing it. Whether it does or does not is really open to question because historically, when you shut things down, it doesn't have a major effect. And there were many other leading scientists that echoed these sentiments in the middle of March 2020. Dr. Michael Osterholm from the University of Minnesota said people are just following each other off the edge of a cliff because they're not thinking. Dr. Tom Frieden, the former head of the CDC, echoed these skeptical measures. The lockdown measures could be worse than COVID, he said. And others, Dr. Justin Lesler of Johns Hopkins and David Katz of Yale and others in op-eds in the New York Times and the Washington Post, which we quote in the book. But the World Health Organization sent a mission to China for a week. They judged after a week there, under the tutelage of the Chinese government, that the Chinese efforts had been successful and that the virus had been suppressed and that the entire world should follow the Chinese strategy of severe lockdown measures. Aggressive case identification, extreme social distancing. The World Health Organization team said this can work in any setting, in spite of the fact, of course, there were mandatory apps and surveillance measures available to the Chinese government, which were not going to be used in other parts of the world. There was a 3.4% prediction or assessment of the case fatality rate at that point. It was known to be way too high, but that frightened people as well. And then, of course, a famous Report 9 from Imperial College London, based on modeled projections by Dr. Neil M. Ferguson, who had a track record of overestimating the mortality of previous pandemics, said that absent extreme and sustained suppression measures, there would be 2.2 million dead from COVID in the United States by August of 2020. And so that date was when the President Trump had a news conference, and schools had already been shut down across the country, but that was a major turning and inflection point. To really, to dispense with the decades of pre-COVID pandemic planning and adopt, in effect, the Chinese strategy. Now, there were dissenters, including Jay Bhattacharya here at Stanford with others who argued for policies that were similar to what Michael Osterholm and others argued for in March. Let's focus protection on the vulnerable. The costs of shutting down the whole society, keeping kids out of school, et cetera, will be extremely costly. Better to focus on those who are at highest risk and concentrate testing and social distancing to protect them. Maybe they were right, maybe they were wrong, but they deserved a respectful hearing, which I don't think they got. Dr. Francis Collins, the director of the National Institutes of Health, emailed Dr. Fauci and others saying, the proposal from the three fringe epidemiologists seems to be getting a lot of attention. There needs to be a quick and devastating published takedown of its premises. I mean, in effect, come May 2020, we declared war on COVID, and as in previous wars, dissent was unwelcome. Dissent was stigmatized, and I think the debate was cut off prematurely. And that was a major problem here. It's not that we made mistakes early on, but that we failed to learn from the experience of others. Europeans reopened their schools in many cases in April and May without incident. We didn't learn about that. It was not reported in the media. In any case, there was intolerance of dissent, I believe, during COVID. So just very quickly, what happened? The governors made the decisions, local public health officials, but states diverged widely in their response to COVID. I'm just going to go very quickly through this. Democratic states closed schools earlier and longer. And indeed, across the whole suite of non-pharmaceutical measures, there was a big partisan divergence with Democratic states keeping their lockdown measures in place much longer than Republican states. All schools closed, but many schools in Republican states, most schools in Republican states were reopened in the fall of 2020, as were European schools, by the way. So if you look at state partisanship and school closures, Democratic states on the right, very strong partisan relationship between partisanship and school closures, Democratic vote and school closures. Overall stringency, Oxford put out this overall stringency index for non-pharmaceutical measures, the whole list of things, and they rated governments around the world very usefully in terms of the stringency of all of these lockdowns, restrictions on gatherings, stay-at-home orders, school closures, and so on. So if you look at overall all the pandemic restrictions, strong relationship between Democratic vote for president and the stringency of the pandemic measures, District of Columbia on the right, North Dakota, Wyoming on the left. So very strong partisan relation. And there was also a partisan relation to the vaccines. In the book, we're not skeptical about vaccines. The vaccines made a difference. Our argument is that we lack evidence in terms of mortality for the effectiveness of these non-pharmaceutical measures when they were implemented. In other words, Republican states did have higher death rates from COVID after the vaccine was available, but not before, once you correct for things like age, percentage uninsured, percentage urban, and a whole variety of other factors. But in any case, so vaccine uptake, also strong relationship between Democratic vote and vaccines. With what results? Vaccine uptake did lead to lower death rates in Democratic states after the vaccines were available. No question about that. The evidence shows that. But all of the other measures, lack of support. Faster stay-at-home orders not associated with COVID mortality. Lengthier stay-at-home orders not associated with COVID-related mortality. Longer school closures not associated with COVID mortality. All pandemic restrictions not associated with COVID mortality. So no relationship in terms of empirical results as opposed to modeled projections. And there's county-level data that validates this at the county level. Again, when vaccines become available, Republican states trend upward from Democratic states, but not before. Thomas Bolecki's work does support ours. He shows that there are reduced infection rates in Democratic states, that the NPIs had some associated with reduced infection rates, but he lacks evidence that they reduced mortality. And we don't think reduced infection rates is sufficient to justify the costs of the measures if in fact there was no impact on COVID mortality. And just to say, Macedo et al., the best study that's available, we think, of the European countries, 29 European countries, greater variation in European countries in terms of the stringency of these lockdown measures as opposed to the American 50 states. No relationship there. The authors of this article find in terms of excess mortality, the average of the previous 10 years. They express surprise at the lack of association between more stringent lockdown measures, the lack of association between those and mortality. What about the cost? That's the other side of the ledger. Sarah Cody mentioned that the mandate of public health and California law is to do what you can to reduce the spread of a virus. But what about the costs of the measures that are undertaken to slow the spread of the virus? Effects on education have been large and persistent. Unprecedented drops in student learning in both reading and math, reversing roughly 2 decades of progress. And the losses are greater in high poverty and Black and Hispanic students. Chronic absentee rates from schools have doubled, now at 1/3 of K-12 students. And these negative impacts on schools and school children were predicted. Pandemic relief was just huge in terms of the amount of GDP and the amount of debt imposed on future generations, equal to the entire New Deal, 5 years of the New Deal, and the 2009 financial bailout put together in 2020. And then we did the whole New Deal over again as a percentage of GDP in 2021, contributing to inflation and probably the change of governments in many countries around the world as well. Crime, the largest year-over-year increase in homicides in U.S. history. Surge concentrated in cities with more young men forced out of work in low-income neighborhoods. 40% increase in firearms sales, carjackings way up, and so on. Inner cities, of course, San Francisco is sort of rebounding a bit now, but it's had years of seeing downtown areas degraded significantly in terms of businesses and foot traffic and so on. Effects on physical and mental health, delays imposed on non-essential elective care, rise in excess deaths, even demographics little affected by COVID, surge in anxiety, depression, eating disorders, measurably higher in counties with mandatory social distancing, increase in substance abuse, overdose deaths, depression, and so on. Depopulation of downtown business districts, depressed church attendance, loneliness, social isolation, and so on. The costs of the measures themselves were severe, and these were predicted. And physical and mental health, of course, the loneliness and isolation of people in nursing homes who weren't allowed to see relatives, significant psychological and emotional suffering, which we document in the book. Any lessons learned? Well, the Scottish COVID inquiry said, and it's a good one, that we lacked evidence for the effectiveness of these non-pharmaceutical measures at the beginning of the pandemic, and we still lack evidence for their effectiveness. We just don't have evidence in terms of significant reductions in mortality for the severe measures that were put in place. There was not really any political price to be paid because governors pursuing very different strategies won re-election. The voters don't seem particularly have noticed, though there's been a considerable drop in confidence in public health among Republicans in particular. And just to quote Francis Collins, this is getting to the end here, respecting public health, the head of the National Institutes of Health, the major health funding agency in the world, his own reflection on the pandemic was this: if you're a public health person, you have this narrow view of what the right decision is, and that is something that will save a life. It doesn't matter what else happens. So you attach infinite value to stopping the disease and saving a life. You attach a zero value to whether this actually totally disrupts people's lives, ruins the economy, has many kids kept out of school in a way that they will never quite recover from. This is a public health mindset, and I think a lot of us involved trying to make those recommendations had that mindset. And anyway, there's much more to be said. I'll skip this last one, but there are questions around the origins of the virus and so on that still haven't been answered and so on. But I will leave it at that. In retrospect, I think we need to continue our careful reassessment of what happened. Decades of pre-COVID pandemic planning had the general view that these non-pharmaceutical measures were unlikely to be effective and would be extremely costly. It seems to us, authors of this book, that the balance of evidence suggests that those pre-COVID pandemic planning documents were correct.